So good morning. We're looking at a person-centered approach to health and social care today. Now, this is a new unit that we're starting. Well, you'll be familiar with person-centered approach if you're working within healthcare at the moment anyway. So there are 4 learning outcomes on here. Yep, 4 learning outcomes. Yep. Learning outcome 1 is understand person-centered approach, values within the health and social care sector. That's what we're looking at today. Learning outcome 2 is understand equality, diversity and discrimination in relation to person-centered approaches. And then learning outcome 3 is understand how person-centered care is applied in practice in health and social care settings. And then learning outcome 4 is be able to review your own person-centered skills. Now, when we go down, like I always pointing this out, the indicative content, you've got little sections here for each learning outcome, and it just gives you a very good idea of what you should be answering, what sort of things you should be adding into your assignment when you're doing it. So it's a nice idea just to have a quick look at this, and it gives you very good pointers. So let's go back up. So today, learning outcome 1, understand person-centered values within the health and social care sector. You've got 4 assessment criteria, 3 are for the pass and 1 is distinction. So 1.1, explain the importance of person-centered values when working in health and social care. 1.2, describe how person-centered care has developed. 1.3, explain challenges associated with the person-centered approach. And then the distinction question, 1D1, recommend ways to overcome challenges associated with a person-centered approach. Now you'll actually see there's a bit of a link from here, from 1.3 to the distinction question. Here we're talking about what challenges they are. Then we're going to use the same challenges and we're going to talk about how we're going to fix them. So how you would change them, how you fix them. So they do sort of link with each other. And let's make a start. So the aim of this unit is to help you develop an understanding of the importance of a person-centered approach in the health and social care sector and how it's applied in your practice in different health and social care settings. So how we actually use it on a daily basis. Now, person-centered care is it's just about focusing on the needs of the person rather than what the service needs. So what sort of plans can they do? What sort of implementation? What can they keep up with if they've got a particular thing that they're trying to deal with? They've got asthma and they need to have a particular medication. Can they take it themselves? Is somebody going to have to be able to manage it for them? Is it a child whose parent needs to be taught how to give them the medication? So it really is about that person focusing on their care rather than what you need to do as a service. So even if though it is a person-centered way where you're actually looking at what the person needs, it doesn't mean that what your patient says is the last thing that you do exactly what they say. You've got to be able to do it in a way where you're respecting their needs and requirements, but also following your own rules and regulations. So some things you can change and some things you can't. You just have to come to a middle ground with that. Now, with person-centered care, we've got personalization as well. Now, this is relationship-centered care. Adi is joining us now. So personalization just means it's a process where people who've got long-term illnesses can receive support, to be able to be done with their individual needs and wishes. Good morning, Adi.
Hello, good morning.
Good morning. So you've not actually missed much. We've just started. We're just talking about person-centered care. We're on the introduction.
Okay,
so
thank you.
You've just missed 2 slides, and that's it. That was just talking about how we make sure that we look after the patient and not our service needs, but the patient's here.
Okay, thank you.
You're welcome. So like I was saying, personalization is just about how you center the care and tailor the support for their individuals' needs and wishes. Now, there was actually a document called Putting People First. It's a paper that was published in 2007. Now, this is where the government outlined its vision to improve adult social care and where they adopted personalization as an agenda. So at its core, what it wants to do is it wants to support people, support services, and have all these, the involvement that you give them, have them be personalized, have them be tailored, be unique to each person. So it's not like a one-size-fits-all approach where you've got a particular process or particular medication that you'll do in a certain way. You know, you've got certain procedures and you say, right, this is all we're going to do. It's not like that anymore. It's like your care will be slightly different. Your care will be slightly different. You do it so that you can actually personalize it and develop and design a package of support that is for that particular person. There you go. So now we're going on to 1.1. So this is about the actual questions themselves. This is explain the importance of person-centered values when working in health and social care. Now, we've already established that person-centered care is about the individual, it's about what they need, what their requirement is, trying to change things and tailor your care according to what they can do and what their needs are. So we're just giving them support, giving them individual attention, because even though somebody might have the same medical condition, they might have diabetes, they might have dementia, they might have asthma, it doesn't mean that they have the same sort of requirements for care and support. Some people might be able to manage it a little bit better. They might have a more supportive family system and a lot more assistance, and others may not have that with their own network. So you're tailoring what sort of support they need. So to work in a person-centered way, you need to have a clear understanding about the individuals that you're supporting. So you need to look at their culture, how they communicate, what they like and what they don't like. You might need to look at what their family is like, if there's any other professionals involved. So it might be yourself that is helping them with their care needs, but there might be social workers that are involved, or there might be the police that are involved, or you might have schools that are involved. So you're really looking at what other professionals are there. Now, there are actually 8 person-centered values, and these are independence. So you're going to help the individual, help your service user, do things for themselves, support them in doing things. Even if it's them just making a cup of tea or choosing their own clothes, you're trying to get them to independent as much or as little as possible. You're going to take the time to help to support them to be individual and independent, even if you're going to get their clothes out for them in 30 seconds, or you'll make them a cup of tea in a minute. It might take them 10 minutes to do something or to walk to the bathroom. It's no point in you rushing them and doing everything for them, because then you're not promoting their independence. Sometimes quicker is not always the best thing to do. And when you're taking the time to let them do things on their own, I know naturally when my children are trying new things and they're saying, I want to do this and that, it's my instinct to take over and say, oh, just give it to me, it'll be quicker. But in that way, you're not letting them feel in control. You're not giving them a sense of self-worth. So supporting independence is very important in any aspect of life. Then we've got individuality. So never make any sort of assumptions. Never think that a person is like this or like that. Never think about someone as what you think what they are as an individual. They don't need to fit in with you or your employer or anybody else around. It doesn't really matter what type of individual they are. They should be allowed to be individual. They should be supported, and they should be able to make their own choices. So care and support, it should be tailored to suit each individual. So by doing this, you're going to be showing them respect, because you're preserving the dignity and their individuality, and also their own different beliefs as well will be respected. This brings us on to privacy. So we know that every person has a right to have time and space to do things in private. So they should be able to make a phone call. They should be able to have their door closed. They should not have the issue where someone's listening to the conversations. So if you go into if you're in the room and they get a phone call, a patient, then in retrospect, you should be walking out and letting them have their own space. Or when you're wanting to go into a room, knock on the door. So just a few little things that can show privacy. Then we've got partnership now. There's a lot of partnership working that does happen. So you might have noticed that in some areas that you work in, you might be involved with some schools, you might be involved with GPs or the community nurses. So you're working in partnerships with other professionals. You might be working with different colleagues. You might have families in partnerships. So if there's a child that requires a certain amount of care, the child might be too young to do things for themselves, so the family is going to be a partnership with you and they're going to provide the care and support. So partnerships, even though you're all working together, it's all about the individual that you're supporting. So you all need to have good communication and you need to be able to share the right type of information to make sure that everything is going as it should. Then we've got choice. Every person should have a choice and they should be allowed to make choices and they should be given support to make choices. So about what they want to eat, what they want to wear, and what sort of programs they might want to watch. Dignity. So make sure that whatever you're doing, that you're helping somebody feel respected. Dignity is extremely important for all of us. We don't like to feel like somebody's put us down or is not following our wishes. So it might, even again, it might be something as simple as what you're eating or when you're sleeping or when you're washing or so on. Just little things that can help someone feel dignified. Addressing somebody in the way they want to be addressed. So if there's a patient who is called Mrs. Edna Smith, she might not like being called Edna or love or darling. She might want to be called Mrs. Smith. So but to identify that that's what she wants and follow her wishes and address her as Mrs. Smith whenever you go into the room. Then show respect. So you might have different cultures or might be an age different. You might have different beliefs. You know, depends, just really doesn't matter what sort of differences there are. You know, it could be age, culture, gender, sexual orientation. When you're working with other people, don't ignore the individual that you're supporting. So if you walk into a room to, say, pick up a piece of equipment that you need, walking in and walking back out silently, that's not respectful. Walk in, say hello, then you can walk, ask them how they are, and then you can walk back out. And again, make sure that they don't mind being called love or dear. Ask them what they want to be called. And the last slide on this 1.1 is each individual, they've got a right to say yes and they've got a right to say no. So if they don't want a particular thing done at that time, they've got a right to say, no, I don't want this. So if you're going in and you know that you need to give them personal care, you need to wash them, you need to clean them, they might not want it at that time. So they do have a right to say, no, I don't want this right now, come again later. So they've got a right to choose what they eat, when they eat, how they dress, when they dress, you know, what they do. They've all got their own rights. So has anybody got any questions or any comments you'd like to put in? So I'm actually going to ask a question now from one of you. Can you give me an example of a time when you've respected somebody's dignity? Any type of examples? I'm going to start choosing randomly, I think.
Hello, this is Placidia.
Hi, Placidia.
Yeah. So an example is, for example, if you're in a care home and it's your turn to do the changing, the rounds,
Yeah.
personal care. Now, while you're doing the personal care, there are some residents that you ask that the door has to be left open at all times.
Mm-hmm.
But during the period when you're doing the personal care, you should have discretion to keep the doors shut because the clothes will be taken off and all that.
Yes.
So that's part of dignity and respect.
Exactly, 100%, that's right. because obviously even though for safeguarding issues they say please keep the door open, I mean, there's a way you can come, I mean, there might be cultural reasons that you need to close the door so someone can't see, and as completely you will respect that in those cases. So well done, that's a fantastic example. So let's go on to 1.2. Now, this section is, I'll read the question first. Describe how person-centered care has developed. Now, these few slides that I'm going to go through now, they actually just tell you how person-centered care develops. So I'll be reading a few parts from here. So please don't mind me if I go on. So in the 1960s, a psychologist called Carl Rogers was the first person who coined the term person-centered care. Now, this was in relation to psychotherapy, and it used to be called client-centered at that time, so just before the 1950s. So even though there's a lot of different ways that you can talk about person-centered care, the key element from these approaches, from client-centered and person-centered, is that you're looking at the person's empathy. You're looking at the professional's willingness to suspend their own judgment, to suspend their own thoughts. So you may have a particular thought or idea that is true to you, but it might be different to someone else. Even though it's different to someone else, it doesn't mean that they're wrong and you're right, or you're wrong and they're right. So you suspend your own judgment. So Rogers actually called this unconditional positive regard. Now, in 1970s, there was another American psychiatrist, he was called George Engel, and he promoted the move from a medical to biopsychosocial model of health. So where you're looking at the biological aspects, the physiological aspects, and the social aspects. So really a holistic approach where you're looking at everything about them. So you're looking at how they think, how they live, what sort of needs they have. So these ideas actually became aligned in the 1990s, so they became joined up. So there was something called a chronic care model, which was developed, and this was there to address any deficiencies in how people with long-term conditions were supported. So any sort of shortcomings that were happening, they started addressing it by then. So in 2001, the highly influential Institute of Medicine included patient-centeredness, and it had 6 aims of healthcare quality. So over the following decades, the person-centered actually began appearing in regularity in the UK. So it started off in America, but then it came here. It started coming within the UK again. Now, in 2000, the NHS created a plan, and this highlighted that we needed personalization and coordination so that we can, coordinate our care and personalize it for each person. And then in 2008, Lord Darcy's report, he reported that a high quality of care for all was needed, that we needed to get a better quality of care within our healthcare system. Now, in 2009, there was the first NHS Constitution in England, and this set out what people could expect from the NHS. So it just put all the statements and everything into one framework where it was, exactly what is expected. So people working in the NHS know what they need to do, and people who are using the NHS know what sort of expectations they can have. Now, this constitution, it actually stated that NHS services must reflect the needs and preferences of patients, their families, and their carers, and that patients with their families and carers, where appropriate, will be involved in and consulted on all the decisions about care and treatment. Now, where it says where appropriate, you would have some patients that may not have the mental capacity to make decisions for themselves, and they may not have the right family network where decisions can be made for them. This will come under the Mental Capacity Act as you go on. Now, with that, it is then a person would be appointed, a healthcare professional, an advocate would be appointed in that case, but that's a different matter. And then the last slide on this one, I know it's a lot of information. Now, there was a lot of times you might have heard of the Winterbourne Review, you might have heard about the Francis inquiries. Now, all these are where serious cases have happened. Now, an example of this is there was a care home in Mid Staffordshire. It was an NHS Foundation Trust home, and between 2000 and 2009, there were things that were happening that shouldn't have been done. People weren't be getting cared for in the correct way. Rules and regulations weren't being followed. So there was a lot of failings and a lot of issues that came up about it. Now, the Francis Inquiries actually looks at these type of issues and sees what can we do to fix these. How is this reflecting on care at the moment? So they always have reviews every few years, and they just to see what have we learned, what needs fixing, and what has been fixed. Is there anything we can do better? So now, person-centered care is central to the policies in the UK. We've got the Health and Social Care Act of 2012. You know, we've got a Vision 2020 for Scotland, so they've got a focus and support a self-management system going on there. And in Northern Ireland, we've got a quality strategy where this goes on patient and client focus. So in total, we've got patient-centered care is coming very much in strong force within the UK now. And it's something, if you're working in healthcare now, you'll already be very familiar with how patient-centered it is. So that was 1.2. We just talked about how patient-centered care and approach came about. Has anybody got any questions they'd like to ask? I'm guessing that you're okay. Either that or all my talking has made you fall asleep. There you go. So 1.3, explain challenges associated with the person-centered approach. So nice and simple on here. So we're just going to look at what challenges there are when we're looking at person-centered approach. So we want to look at improving our approach here. We want to improve our access. We want to improve our communication, and we want to improve our collaboration. So collaboration is when we're working with other teams or other colleagues or families or other professionals. We want to tackle things like, staff attitudes, or if there's a service attitude where you think, oh, we've always done this way. It might need changing. It might not reflect how things are being done now, so you need to tackle those. And then we need to create the culture, individualize care, and unlock the patient and family resource. And we'll go into detail. So when we're looking at this, we're looking at the importance of professional identity. So it's nice to have a desire to do good. It's more or less people that go into healthcare will have a desire to want to care for others. They've got a passion where they want to support others within the community. So even though we want to do good as a society, we want to, change things and improve things and actually address any issues, sometimes there can be problems that will come up about it. So you might have barriers that come up. So we know that there's things that you've got barriers. We might have barrier in practice. We might not have enough training. We might have an attitude where we say, we already do this. Why should we change? Why should we change our systems? Why should we follow what they're doing? I don't understand why we need to listen to the patient anymore, and so on. That type of thing. So there can be some issues that can come along. There can be issues with training, like I said. There might be issues with sharing decisions or even trying to support others to manage their own symptoms or manage their own medication. And also, again, about how receptive we are about wanting to do better. Do we want to address this? Do we want to bring it on ourselves and say, right, yeah, I actually want to do it? Or are you saying, no, I don't want to address this. I'm not receptive to this at all. I'd rather stay the way I was. And we're coming on to training teams. So because we're talking about challenges here, we're talking about what sort of things that can go difficult in here. So again, where you might have a team that's working together, you might have a lot of different people coming together to do things. So it's important that these teams are trained. So you're not just training an individual, you're training everyone in total. So if I was to go and get a training session in how to, say, use IVs, I might go in and I've been taught, and like, oh yeah, if she knows how to do this, she'll go. But I can't be in every single place at once. I shouldn't just be me that's getting trained. It should be all of us that are getting trained at the same time, so that we can work as a team rather than focusing on that one person who may be in sometimes, who may not be in, who might be busy with something else. So if everybody is trained at the same time, it means they're sort of speaking the same sort of language. They've got the same understanding, they've got the same motivation, they've got shared goals, they know the practices and procedures that need to be done because they've all went to the training together and they know that this is right, this is how we're doing these things. And then this will support the infrastructure, and this actually translates into the practice that you do on a daily basis. And then the importance of starting with clinical leaders. Now, the hidden curriculum is a powerful force within the NHS. It's not enough to change education and training. So teaching the trainers who role model behaviour and practice first will have an impact on both current practice and the training of next generations. So when we say teach the trainers, it's say in your workplace, you might have a particular person who's always coaching you or mentoring you or giving you new ideas. You might have a manager that has gone on training sessions a lot. Or you might have a trainer who's there who actually, comes and you shadow them, you mirror them, and you go and look at them all the time. And they're teaching you how to do some procedures. Now, if that person is taught how to do things correctly, because they're the trainer, they'll be able to pass on the correct information to you. So it's very important to teach the trainers. And then the last section on here, the importance of new roles. So developing both the capacity and capability of new roles, such as peer workers, health coaches, and care navigators who work within and alongside traditional services, highlights the demands of carving out a new training pool. So you're using the existing resources, but then you're creating new roles that are actually identify that they need to be there. So we've got a very big issue with obesity within the UK. It's rising, especially within children as well. So having health coaches there to work with them, to try and teach them tips and tricks to improve their health and well-being. It's a role that needs to be there. Peer workers need to be there. Care navigators, somebody who can, navigate and implement in between different care services. All of these roles are something that need to be there now, and it's identified, especially with person-centered care. They've become a lot more popular now. So that was 1.3. We looked at some challenges, so training, development, your own thoughts and judgments on things. Does everybody have any questions they'd like to ask? Okay, so let's go on to the last section. So 1D1, recommend ways to overcome challenges associated with a person-centered approach. Now, we looked at some challenges, so training and so on, that might need to happen, but also having new roles created. And now we're going to look at how we can overcome some of these challenges. So we've got a holistic and joined-up approach to change. Can somebody tell me what holistic means? So ATHE, would you know what holistic means? You got an idea?
No.
Okay, it's not a problem. I'll let you know. Holistic is just everything in general. So you're looking at a patient. So you're looking at me. I'm your patient. And you're going to look at every single aspect of me. You're going to look at my family life. You're going to look at my religion, my culture. You're going to look at my age, what I do for work. You're going to look at what sort of support system I have, what my mental capacity is, if I've got a good environment to live in, if I can get to my appointment. So really, you're looking at every single thing that makes a person up or might affect their care. You're looking at everything. So just imagine you in the center, and all of these aspects, your family life, your work, your environment where you live. Have you got hot water? Have you got good food? Do you have a supportive family? What your mental capacity is? How you are emotionally? So you're looking at everything about a person. So when you're going to look at recommending, looking at overcoming challenges, you're going to look at a person as a whole. You're going to look at, seeing what sort of things you can do to reflect. So if you have a patient that's come in who needs insulin shots, now those injections need to be put in the refrigerator. Now, if there's a person who doesn't have access to a refrigerator, they might be living on the streets. How are they going to be able to look after themselves? So you do need to, bring that into aspect as well. So do you understand what I mean?
Yes.
Yeah, fantastic. So person-centered care requires a holistic approach to secure change locally. So it needs to be supported by national labels in the 3 areas. So the first area is supporting individuals to understand, appraise and apply health information, to be knowledgeable, skilled and confident in managing their own health, and to be motivated to become active partners in their healthcare. Then you're going to support healthcare professionals to recognize the need and to develop the necessary confidence, skills, and knowledge to take on new roles and to work in partnership with patients. And then finally, you're going to build an alignment, so you're going to build a bridge nationally and locally, and you're going to measure the processes, any financial issues, any guidance, and you're going to look at the regulation to support and encourage these new relationships and roles. So just got a bit of example here. So this is about shared decision making and self-management. So we're going to look at current practice and person-centered care practice. So we've got roles and beliefs. So in the current practice, this has changed a bit since this slide was made, so it's getting a lot better now. But current practice, patients are passive. They believe that the doctor or the care worker or the nurse, they've got all the answers and they're just going to go and fix things for them. But in person-centered care, people are active partners and they're managers of their own health. So it's where the clinicians care about them and listen, and they use their expertise to support them. So before, policies and practices were just about just basic and simple, but now policies and practices have changed to reflect these changes. Now, when I used to go to the doctor when I was younger, I'd go in, I'd say, oh, I have this X, Y, and Z, I've got these problems. And they just turn around and write me a prescription and I'd go off. I still wouldn't know what my problem was, what it's called. All I know is I've got a cream or I've got some medication, some pills that I need to take. But now I can go in and I'll feel more confident and comfortable in saying, what is this cream for? What have I got? What is this rash? What is this spot? What is this ache? So you can actually go in and actively question without feeling like you're, putting someone off. So originally, current practice is just a primarily medical practice, but person-centered care is biopsychosocial. So you're looking at biological aspects, your physiological, your mental aspects, and then your social aspects of your life and your environment. And then how is it done? So current practice is where the clinician will share the results and information during the consultation, and then they'll just communicate things and get the patients to agree with them and say, right, you need this cream, you need this tablet, take it 3 times a day, and you're done. And you'll be like, okay, and you'll walk out with your medication. But now, with person-centered care, it's where the patient will receive their results and they'll get the information at an appropriate time, and it'll help them to set an agenda and make their own decisions to see if they can keep up with the treatments that they've done. Are they able to afford the medication that, because not everybody is liable to have free medication. So if they've got something they need on a monthly basis, can they afford that £13, £14 for the prescription that they need to give now? So that was just the distinction question. Just turn this off.